and sitting down to listen to everything, but we have a lot of information, and so I want to make sure that we have a chance to get through everything. And as questions come in, we will try to answer those as quickly as we can and maybe have some time at the end to cover a couple of things. So I want to welcome you to the 2017 Final Rule Summary for Radiation Oncology as presented for the ACRO members. As you know, we are based out of Austin, Texas, and we have a website with some different available resources on it. But if you have any questions that we weren't able to get to today, maybe need a little more info, you can use the info@revenuecyclelink.com email address and just let them know that you attended the ACRO webinar for Final Rule and post, send us the question or the information that you need there. My name is Terry Bedard. I'm the Director of Corporate Consulting. I've been with Revenue Cycle for about almost 9 years now, and I worked in a clinic in that beforehand. Amanda Kloon is also one of our consultants, and together, the two of us, one of our priorities or one of our major responsibilities is reviewing the proposed and final rules that come out each year, going through those, figuring out what is pertinent to oncology, medical, and radiation, and then providing it to you in hopefully in a manner that's easily understood. You can take away some of the highlights and things that are going on and present it to you so that, it's something that's usable for you as well. A couple things with regard to housekeeping. Everyone is muted, and that's just really just going to help out so there's no distractions in the background and so forth. If you have any questions, I would ask that you please use that Q&A portion over to the right-hand side of your screen. That will really help us in kind of going through those. We'll try to get them as quickly as we can. And if you use the chat function, that's fine. It's a little bit sometimes more cumbersome at times, but the QA should be able to help us, and we'll try to answer those for you as well. I'll try to leave some time towards the end to ensure that we can cover some questions that maybe came through that are maybe a little too lengthy, maybe we got repeatedly to kind of highlight. But we're going to be covering quite a bit of stuff, and so I want to make sure, be able to pay attention and see, listen and see actually what we have for next year. If you registered for this, the email address that you used to register for this webinar is the email where we've already sent out a PDF version of this presentation. If you have not received it, look in your junk or spam email, or you can use that info and just say, I attended the webinar, can I get a presentation for this, or a PDF of it as well, and we'll send it to an alternate email address or a different one from what was provided to us. So just keep that in mind. You may already have one in your email if you haven't looked at it recently. As we go through the information, one of the main or key component things to remember is that there are some changes for next year, obviously, but there could be changes throughout 2017. With a couple things going on in hospitals, I'm not going to spend much time on hospitals at all, but there's some things that could be adjusted in 2017. We still have a month and a half until the end of the year. So there's always that potential for correction notices, different things to come out. CMS is going to be releasing some more information on a couple of things before the end of the year. So always keep that in mind when you're looking at the information, that there could be some adjustments to even what we've presented and what had originally been finalized in this webinar. So to kind of go over the objectives, what are some of the main points that I want to cover and make sure that we spend some good time on. I'm going to briefly go over the different settings. And the reason for that is just, again, to highlight and make sure people understand the difference between HOPS and MPFS and where they fit into that. So we'll spend just a little bit on that. I'm going to go over just a few highlights for hospitals because since this is really directed towards physicians, I want to make sure we have time with the MPFS, and we are going to talk about the quality payment program, which is really in response to MACRA. What was the final rule that was released for that, the items outlined in that. So that's going to be the bulk of what we're looking at. The hospital stuff, like I said, just very, very few details with that. When it comes to the payment systems, right now we have HOPS and MPFS. HOPS really pertains to our hospitals and ASCs, ambulatory surgical centers. It's based on cost, so by law you do have to report your costs to Medicare each year, and they use that information from all hospitals to then start setting the reimbursement for CPT codes. It does matter where you're located. There's a wage index that is assigned, and it depends upon if you're in a rural or urban county, and by state there are very different jurisdictions within each state. And then they're grouped into APCs. So there are groups of codes that within that grouping, their costs are similar. You look at the work that's provided is similar. So everything in that classification is paid the exact same amount by Medicare, regardless if there was a hierarchy. So traditionally, as we've seen in hospitals, our 3D plan, 77295 and 77301, our IMRT plan, are paid the exact same amount in a hospital setting. On the flip side of that is the Medicare Physician Fee Schedule. You may also see it as PFS, where they just drop off the Medicare part in some of the literature and transmittals. This really pertains to physicians and office settings or freestanding centers. It doesn't matter if the physician is employed by the hospital. It doesn't matter if they're an independent group. They are going to follow the reimbursement and guidelines under MPFS, even though the entity that they work in may follow something else. The reimbursement is established through RVUs, or relative value units, which most of you probably know that. We've got malpractice, practice expense, and work RVUs. And all of that still traditionally has been, and still for the next couple of years, has been applied with a conversion factor. And this is a factor that's set for all of healthcare, and it turns everything into a dollar amount. We'll talk a little bit more about that. And then geographically, the GPCI, the Geographic Practice Cost Indices, really depends upon where you're located. It does have an impact. You know, I always use the example, and I'll probably continue to use it for some time. I live in Des Moines, Iowa. That's where I'm actually located right now. And I know my cost of living is very different than, you know, San Francisco. So I expect when I look at the rates that Medicare has for San Francisco versus Des Moines, there's going to be a difference because the cost of living, a geographic difference. So that impacts the reimbursement as well. As you know, we also have under MPFS, we have global codes. And a lot of our radiation oncology codes have that technical and professional component. So when you add them together, have that global amount, which is different than hospitals. You will see a hierarchy traditionally with regard to different services. So if something is simple, intermediate, complex, you will see a difference in the reimbursement. And ironically, this year we've got some differences with actual devices, how the RVU has been valued. And for some time, there is a difference between each of those levels, 332, 333, and 334. But traditionally, the intermediate device has really been very low value, and a lot of it's due to utilization. We're going to see a little bit of a change next year with those codes. So the whole reason that we're really here today is to learn about what happened in the Federal Register. What are the finalized rules for next year? The Federal Register is where you can find many different documents, the sets of those being the final and proposed rules. The hospital rules, the HOPS will have their own set of documents, their own rules, and then MPFS will have its own. HOPS was just shy of 1,400, and the MPFS was just above 1,400. We're going to talk about the quality payment program that was part of MACRA, our response to that. That was 2,400 pages. So about 5,100 pages over the last several weeks to kind of read through, figure out what's going on, and summarize it for everybody. But to know, you know, the proposed rules, we talked about this, they come out around the 4th of July holiday traditionally, around the beginning there. And it's really, this is what is expected. This is what they're expecting to do, they're hoping to do, this is what they propose to do. The final rule in response to MACRA came out actually in the end of April of 2016. So I'm not sure where they're going to do with any changes and things going forward, what that schedule is going to look like. And then they give you 60 days to comment, and then by law, traditionally, the rules are supposed to be released by November 1st. The quality payment program was released on October 14th. The HOPS final rules were released on November 1st, and MPFS on November 2nd. And so we're going to talk about what was in those final rules. You have the links here. This is for hospital. They leave it in a sort of temporary release on the Federal Register in about 2 weeks. So usually during this week, actually, time-wise, they're going to actually put the final reformatted version that you'll see going forward under the Federal Register, but you can still use this link to get to the final rule document. I just want to cover just a few highlights for hospitals, and then I want to spend, like I said, the bulk of our time going over everything else. There is going to be a slight increase in payments for hospitals. This year we had a slight decrease, so we're going up a little bit. But we do have some changes in how we've classified, or how CMS has really classified and grouped some of the codes together. So there are some codes that even with this reimbursement increase are going to see some negative impacts to them. So we've got quite a few that are moving around and being reclassified together. I think one of the biggest sections and the bulk of some of the really the hospital ruling that came out pertaining to provider-based departments. They really have two designations now. You are either considered an accepted off-campus provider-based department or non-accepted off-campus provider-based department. And it really depends upon some of the guidelines established by the Bipartisan Budget Act of 2015, which gave us a hard date of November 2nd, 2015, as determining who's grandfathered, who's not, what are some of the criteria. One of the main things to realize is that if you've been a provider base for some time, it's pretty much going to be status quo if you were established before that November 2nd, 2015. If not, if you're now considered non-accepted off-campus, you're now looking at still billing on EUB, but your reimbursement is going to be half of what a hospital set rate is for that code. It's a little crazy. You're going to be using G codes. There's a lot of stuff going on. So if you need some more information about that particular, let us know. Like I said, I didn't want to spend a whole lot of time. I want to focus primarily on physicians and our, the freestanding cancer center settings. There is a quality measure to be aware of in a hospital setting, and it's the external beam radiotherapy for bone metastases. And the reason I want to really touch on this is because it does involve our physicians. So even though this is really a hospital quality measure, if they don't report it correctly, they can be dinged 2% of their overall reimbursement because of it. So there is going to be some interaction with our physicians to making sure that this is, following the guidelines, it's reported, and looking at these 4 different fractionation schemes that they've established as part of this quality measure will be very important. Overall, for hospitals from this year to next year, not a lot of negative changes. When we look at IMRT, really some of that comes down to some of the initial devices, some fluctuations just a little bit for some of the planning, but not great there. Proton, the treatments. The treatments went down in reimbursement. They didn't address specifically in anything language-wise as to what was going on with that. And then when we look at the partial breast, that's coming down to some of our, again, the simulations and some changes from the codes there. So overall, for hospitals, not drastic, other than with the proton seeing some changes. Okay, and that's all I want to talk about with hospitals. I want to spend the bulk of the time now on MPFS and the quality payment program. Here's the link that you can go to, again, to find MPFS. Like I said, they'll have the full release in the different format. Should probably be this week, but you can use this link to find it on the Federal Register as well if you want to look at it. Okay, so what's going on with reimbursement overall? We know that we're in some definite changes that are coming and what's exactly going on. This is all, a lot of it is in response to what came out with MACRA, which came out in April 2015. And as you remember, traditionally we'd always had this conversion factor that typically, Medicare has to be within that $20 million above and below this budget that they have each year. And so we would have these conversion factors that would swing so low, 25, 30% reductions to get into the budget, and then Congress would come back and say, well, we can't do it that drastic, we're actually going to raise it a half. And it just was not sustainable. So that went away, and Medicare really set out a timeline for what reimbursement is going to look like. So that's what MPFS is looking like starting to, and that's what the whole quality payment program. Through 2019, the conversion factor as we know it is going to continue. It's supposed to go up 0.5% each year. And then we start getting into the quality payment program, the MIPS, then we start getting the APMs that will now drive and determine your reimbursement as physicians going forward. But for right now, we're still using the conversion factor. It still has a dramatic impact on what reimbursement can be. It is going up slightly for next year, I think, as composed to 2016. So they took the 2016 conversion factor, added 0.5%, and then because of that budget neutrality of being within that range that they need to maintain, they had to subtract a little bit, that 0.013%. Then we have a target recapture amount. This is in response to misvalued codes. So there's these high-screen tools that look at codes to determine if they possibly are misvalued. And if they've been undervalued and now Medicare has to pay more because they've been revalued at a higher rate or higher RVUs and so forth, that now also impacts the budget. So they're taking a little bit away next year to account for some of the extra money they have to pay towards that. And then the imaging multiple procedure payment reduction. For the last couple of years, there's been this 25% reduction when a patient has the same imaging procedure by the same physician during the same day. They pay the initial one, and then there's a reduced price paid for the subsequent ones. And typically, it's about 25% has been the reduced price. Well, 2017, part of MACRA, a lot of it's changed in that it's now down to 5%. So now we've got, again, more money going out because of new legislation. And so we have to account for that to maintain that budget. So all said and done, the table you see, we're going from 35,8043 to 35,887. So a slight increase. And we take, to determine then what each CPT code, how much is that SIM worth, how much is that plan worth, what's the physician work, how much work does the actual physician, put into this service and geographically where they're located, what's the overhead, what's the indirect and direct practice expense associated with, the lights, the treatment planning system to maintain it, et cetera, and where is it located, and then malpractice. This is where, even radiation oncology has a malpractice value. We look at, how risky are procedures and so forth, and that's where they put that value with that, multiplied by the conversion factor, and you get your reimbursement amount for each individual CPT code, and that's how they calculate it under MPFS. Overall, for radiation oncology, we're not looking at an impact. I mean, we're looking at pretty much status quo. Obviously, there'll be some changes. We've got an increase in that conversion factor slightly. We do have some RVU changes in 2017 that are going to negatively impact some of our CPT codes. So there will be some decreases, but overall, when you look at it from the grand scheme, we're looking at basically status quo from this year. The Geographic Practice Cost Index, and this is where, again, it's location. Location makes a difference. And it's a factor that's applied to account for the geographic location of where a facility is located, where the services are provided, and to determine how that impacts what's going on. So it's required to be adjusted every 3 years. And so this is where they've gone through and then looking at populations and looking at determining how things are shifting. So there's been a couple things that have been updated for next year. So per MACRA, the workship fee is going to be at 1.0. That's extended through the end of next year. So that's being carried through. There's no change with that. Everybody, so if you have maybe your values have been lower based upon where you're geographically located, everybody has at least the base of 1.0. There are some other adjustments that are also being made in 2017 that could impact reimbursement. We'll talk about frontier states and California. Frontier states are really our low population states. We think about Montana, Wyoming, North Dakota, South Dakota, and Nevada. They are considered frontier in the fact that 50% of their counties are frontier and their population per square mile is less than 6. So when you look at the services they provide, their reimbursement could be very low, but because of the population, it could really negatively impact them overall. So they're continuing to also extend to them the practice expense, the GPCI at 1 as well. So if they had been lower, they're going to be at that base to kind of help set a baseline of reimbursement for them so it's not so significant or any negative impacts. New Mexico is not considered a frontier state at this time. It's really just when you look at the map, it's really that upper, I guess, north, maybe not quite west, the northern part up there, those states. When we look at adjustments to California, so this is something that's going to, for those of you in California, I'm not sure how many of you on here are from there, but this is going to impact you over the next 6 years until it's completely done. Basically what happened is, again, through MACRA, is there was a change in California in that their fee schedule areas, so basically each state under MPFS is divided into, for most states, not all, it's divided into different jurisdictions, and within that jurisdiction, that's how your reimbursement is set. Currently, California has 9 different jurisdiction localities. They're going to 32 next year. What happens is that it now has to be set for just California, so this is not other states, it's a little different for California. The metropolitan statistical areas, as defined by the Office of Management and Budget, that's how we're going to determine what your jurisdictions are. And so if it was an area that was located, that's not really located in one of these metropolitan statistical areas, you're going to be considered rest of state. What this means is that over the next 6 years, they're going to gradually shift from what you currently are valued to these new values. And so they're going to take 1/6 of the new stuff and 5/6 of the old stuff for next year. Then it'll be 2/6 and 4/6 and so forth until these reimbursement and adjustment change values are in permanent effect. 58 counties currently in California, out of those 50 of them are going to be changing their jurisdictions So your values could very well be changing. You could actually be looking at some lower reimbursement depending upon how they value your specific area. So keep that in mind if you're in California. There's a table that breaks it down within the final rule specifically. We have quite a few codes that we're looking at that are revalued for next year, and this is where we're going to see some negative impacts to the reimbursements for radiation oncology. One is the G6011. It's a treatment code, and it is for up to 5 MUV, but multiple areas. And what's interesting about this code is that what came out last year at the end of 2015 in PAMA, the Patient Access and Medicare Protection Act, it actually froze the G codes, all of them, through 2017 and 2018. They cannot be, the definitions cannot be different. The inputs and values have to be the same as they are in 2016. So when you look at the actual overall value for the code, it's down 10%. But you're like, wait a minute, how is that possible? Well, Medicare uses claims data from previous years. So the data that they had used for 2016 typically was in 2014. They're using that data. And it actually showed that that code was billed 51% by dermatology and only 43% by radiation oncology. So the indirect practice expense assigned to dermatology is different than it is for radiation oncology. And so when we look at that, it had an impact on how the value was set for, for 2016. So they expected, for setting them for 2017, it should be the same. I mean, if dermatology is really reporting this code that often, well, it was a complete almost 180. When they looked at the claims data from 2015, 85% was now reported by radiation oncology and approximately or almost 6% by dermatology. That's a complete shift in reporting of this code, which speaks to some other things going on probably with regard to this code being billed. What happens is that impacts the overall practice expense for that code, and so it had to do a slight shift. They couldn't do a revalue because of PAMA, so there is a change in that code for next year for those of you who may be using it, devices. They basically, what they proposed is what they finalized, in that the RUC had recommended no changes. However, they thought that maybe there was some overstating of some of that work, but the research they found was that 34% a decrease in the time it actually takes to create a simple device. And the RUC had really not incorporated that into the recommended time value or into the value. So one of the other key things is that Medicare decided they are going to change 77332. The value is going down, but it's a hierarchy of codes. So if the simple goes down, intermediate and complex have to go down as well. And so actually for next year, the simple and complex treatment devices, 332 and 334, are going down in reimbursement. The code 333, the intermediate, is going up 508% technically, because right now it's valued about, what, $967, and it's going to go up at $44.63 because of keeping it in line with this hierarchy of codes. 77470 is a special treatment procedure. This is a code that was also identified through a high expenditure specialty screening tool that they have to kind of look at codes that haven't been reviewed in some time. The amount of revenue they generate is typically over $10 million. And they did go ahead and accept the value from the RUC, but there is a lot of concerns on CMS's part about this code. They didn't feel that the description of the code really valued and really addressed the technical work that's going on with it and the professional. And they had suggested maybe some G codes. Those have been shelved for now, but they do have some very serious concerns on how this code is really set and valued. So I would expect, I'm guessing, over the next couple of years, we may see some very distinct differences with our special treatment procedure. The RVUs for work are going down slightly from what we have, so there is a decrease in reimbursement for that going forward. The next one is 77778, our complex interstitial treatment, and then 77790 is our handling and loading code. So the 90 code has not been deleted. It's still a valid code in 2017, but it's really been removed from use from everything. We can't report it with any interstitial or brachytherapy codes. We can't report it with any radiopharmaceutical codes. It has zero work value. But what they did is that when they changed the definition to include handling and loading in the 77778 code, the treatment, they didn't increase any RVUs with that, regarding work. And so there was a lot of, going back and forth, why was this not adjusted? In reading the final rule, there was a lot of discrepancy between the RUC and between the Specialty Society about how this code is actually valued. they couldn't actually agree as to what actually goes into the work, what is actually the components of 77778. And so after considering everything, all the information that came in, the CMS did go with the recommended, adding that handling loading value into the 77778. So that work RVU is going up. They did slightly also increase the corrective expense, but they are really looking for more feedback. What actually is the work included with the interstitial complex treatment? What's the pre-time? All of that. They want to see some cohesiveness more with RUC and the Specialty Society on that code. So looking at these codes that we just talked about briefly, you can see what they are currently, the work RVUs. They proposed, and really basically accepted everything they proposed except for the 77778. So we've got, for the most part, slight decreases except for that one code for next year. Looking at that, well, I'll show you some of the reimbursement coming up. One of the other change code-wise for next year are sedation codes. And they created a whole section of them. I don't have all the detail in here. It ranges from 99151 to 99157. They are age-based. They are based upon, how you're going to report things as to whether or not who's doing the sedation and the procedure. What they found is there's a lot of endoscopy codes that include sedation. And if you're used to using the term conscious sedation, it's now moderate sedation. So we've transitioned a little bit to a different term. But what they found is there tends to be a trend that the practitioner, the provider doing the endoscopy is not the same one doing the anesthesia or the sedation. And so now these placement codes, the endoscopy codes, all have sedation factored into them. But if somebody else is doing it, we need to factor it differently. So they created these new codes and realized they needed to change a lot of those other codes out there. So there's several placement codes that we use, marker placement codes, ham and ovoid, hyperthermia treatments, that all had a value for sedation into them, incorporated. They're all going down 0.25 on the work RVU for next year. So these codes, when we look at, the breast device placement, we've got these endoscopy codes, with the markers, ham and ovoid, and then our hyperthermia treatments. They're all going down that 0.25. So you can see some negative terms in reimbursement for those codes. This is just a quick synopsis. You'll have time to look at this a little bit closer of the impact for all these RVU changes that we just quickly went through. And you can see where the simple and intermediate codes, simple and complex are going down, intermediate is actually going up for next year. When we look at our special treatment procedure, that's going down. All these placement codes are going down. And so, and that's where we'll have that, so that's where we're going to see some impact when we look at negatively at some of the different courses for that. Physicians and provider-based departments. So I talked just a little bit about hospitals. I want to talk and address the physicians who are in provider-based departments. As far as the light sedation code, I think we can try and look it up. I know there's just right now, it's just a simple, the moderate sedation, but there's a whole series of anesthesia codes, and so we'd have to look sometimes in specific areas of the body for that, for some of those CPT codes. There's different sections, a question came through about that. For physicians and provider base, a couple things to keep in mind. For the most part, next year, it's going to be fairly status quo for you, in that you're going to continue to bill on 1,500, and it doesn't matter what type of provider-based department you're working in. Okay, it doesn't matter if it's an accepted one, it doesn't matter if it's a non-accepted one. You're going to continue to bill on a 1,500, and you're going to continue to use that place of service 19 to reflect that it is off-campus, because either one are considered off-campus. And you are going to continue to be paid under facility rates. Medicare had proposed to pay physicians under the non-facility rate when in a provider-based department. This is where things are going to get a little sketchy for hospitals and difficult, is that the provider-based departments are considered facilities. They have to follow the hospital rules, but going forward, reimbursement rules are going to be derived under MPFS. But for physicians, there's not changes for you next year. You will continue billing as you have been and be paid as you have been, essentially, not accounting for changes in reimbursement for next year. The recoupment of overpayments. So historically, when an overpayment was done, CMS would go after, the NPI and try to recoup that payment, and they would try and weren't always successful. And they would turn it then over to the Treasury Department. And each time they did, they had to pay the Treasury to do this for them. And now, per the Affordable Care Act, CMS and MACs actually can now collect those overpayments without using the Treasury. They can actually now collect from the TIN, just as the Treasury was, if they cannot successfully recoup money from the NPI. So this is an example that was in the proposed and final rule. It hasn't changed. This is an example that CMS gave to kind of give you an idea of what that means. Let's say somebody, Hospital A has, they've had a Medicare overpayment, and Medicare has tried unsuccessfully to get that paid back to them. But also within their system are hospitals B and C, and they're all part of this TIN. They could then go to, basically recoup that money across that, and not just from that one provider, but they have been unsuccessful in recouping this money. They proposed that they were going to send out letters to everybody to let them know, and they've said, no, listen, we've done our due diligence to try and collect the money. We are going to put the information out there. You will have to do your due diligence now to be up to date and understand how the process works. So through this final rule, the Medicare Financial Management Manual, demand letters, MLN matters, that's where you'll find the information on recoupment. There'll be some more information before the end of this year, before January 1st, to kind of explain this a little more so you can understand what the impact will mean if there's an NPI that has not successfully repaid overpayment and what that means for everybody else and their responsibilities for that. The Medicare Advantage program is, we have so many, we have all these different entities with regard to coverage for our patients. And those traditionally under Medicare are called beneficiaries. Under Medicare Advantage, they're called enrollees. It's the exact same, it could be, it's the same thing, they just use the term a little differently. What Medicare wants to do is they want to make sure that those who are providing services under the Medicare Advantage program are appropriate to receiving that money from Medicare, essentially. So you have to have an approved status through Medicare first. If you've been revoked at any point, you would not be able to provide services under Medicare Advantage. Plans that are included under this that would be locums and any incident to suppliers also have to have a Medicare approved status in order to provide services in a Medicare Advantage program. And this is, again, to make sure that that money is appropriate. If an organization or program does not ensure that those providers and suppliers are appropriate for these guidelines, there are possible sanctions to that organization or program and possible termination by CMS if they find that the providers and suppliers are not appropriate in this type of program. Physician self-referral law updates. This is something, that's been in place for some time. I just want to highlight it. They've updated the codes over the last 2 years, all the radiation oncology change codes, all the G codes have been added. But I wasn't sure that a lot of people really knew maybe that this existed. But those designated health services are updated annually. And really, there's 4 categories of codes. And within those 4 categories are codes that are subject to the physician self-referral law and things that cannot be, that there are limitations as to what can be referred for services and reimbursement. Radiation therapy services and supplies is one of those categories. So when you open that up, you can use the link at the very bottom of the screen there. You will see all the radiation oncology codes listed in there, the 77 codes, the G codes, and so forth. They did take a couple codes out for next year, the 00119 and the A9545, which may not be codes that you typically use anyways, but I wanted to highlight that those are changed. And to let you know, something to be familiar with. We get a lot of questions about different ventures, agreements and things like that, and where do things, can we bill for this, can we not bill for this, how do we set this up? So transitioning to that then, there are some changes with regard to office space and equipment rental as well for next year. Essentially, a physician cannot refer a Medicare beneficiary to another entity with which that physician has a financial responsibility, relationship with, and that entity that they referred to cannot then bill Medicare or the beneficiary, it could not be a third party, et cetera, for those referred services. Essentially what they're doing is they're establishing and limiting what some of these agreements may look like. They had a lot of concerns when it came to per unit or per click agreements that may incentivize physicians to Uber and do like an over-referral, over-utilization of things because they're referring to someone and in turn they're getting some kind of reimbursement incentive from that. So CMS has proposed and finalized some changes for next year. Basically what they've finalized is that rental charges cannot be determined using a formula based on per unit of service charges in which the services provided to that patient are referred by the lessor to the lessee. What does that mean exactly? If somebody owns that office, owns that equipment, whatever it may be, they cannot refer patients to whomever they're renting that office and equipment to treat those patients, to bill Medicare or other entities, and now get a financial incentive for that. There has to be a break in there, okay? So they've limited this where the lessor is guaranteeing, that they're not generating some kind of payment because they've referred someone for a service to the person. They're also leasing equipment and space too. It's still being done. I mean, arrangements can be had between different entities, but there cannot be that referral from the lessee, or the lessor to the lessee. So the person owning cannot be referring people for services to that person. They're also renting the equipment and so forth from. So this is where looking at agreements, what kind of things are in place, because this is changing. The language is changing for next year. Okay. Overall, MPFS, and overall really for radiation oncology and also in medical oncology, not a lot of changes fundamentally to our coding, like we've seen, especially in radiation oncology the last 2 years. We've had a lot of coding changes. We're kind of, in these next 2 years, 2017, 2018, we're kind of going to be holding steady, I think, for the most part, for a lot of stuff. 2019 is going to be the magic year where we're going to see, I think, a lot more changes because of what's coming up with MACRA, the quality payment program, some of the changes of the G codes that are supposed to be, changing, going into effect there. So this is where, for the next 2 years, for the most part, and this year, going into 2017, not a lot structurally, but I like to say from, the foundation of some of the stuff is really shifting and changing in healthcare. So when we look at the total courses, the main changes are basically due to some of the codes that are changed when it comes down to those devices. We're looking at those. That's where you're going to see some of the changes in the 2D. You see the 3D, the SRS as well. It's really those device codes. And then the TAM and ovoid, when we see the sedation change within that TAM and ovoid insertion code. Otherwise, not a whole lot of difference from that with regard to reimbursement. These next few slides, I'm just going to, you have these. You will have this PDF. Some people like to see a visual kind of representation of this year to next year, what it looks like. And so you've got that to look at. I want to now make sure we have time to get through the quality payment program and address, I think, a couple of questions, more questions coming through as well. So I want to make sure we have time at the end to address some of those. Okay, the quality payment program is, it came out October 14th. It was 2,400 pages long, so that's fairly expensive. You can find it here at that link. It has been officially, posted to the Federal Register, so you'll see it in a different format than when it's first posted. This is really the response to MACRA. So when MACRA came out in April 2015, it had a lot of different changes for Medicare going forward. And a lot of those changes are starting, or big changes are starting in 2017 as we ramp up to reimbursement going forward. Some of the things that it really had provisions for is that MPFS, there are a lot of changes with that conversion factor stuff. Now we have to establish, there's a merit-based incentive payment system, MIPS, that's going to be really front and center, transitioning everybody to alternative payment models. It's really going from volume-based to value-based. So we've been volume-based, we still are, and we will be for here a little bit, but we're really transitioning into more of a into a value-based type system where there's going to be that baseline of reimbursement, but really beyond that base depends upon what you do as a physician. So as we talked about earlier, the SGR is gone. The conversion factor, we're still in this where it's going to be going up. So that conversion factor still has an impact on our reimbursement through 2019. 2020 to 2025, that's where it's going to be 0%, and it's truly based on your performance in the MIPS program. That's where that value base comes in, and that's where you're going to have just that base setting of a reimbursement for a code, but actually what you really get paid is based upon everything else. 2026 and beyond, this is APMs. I mean, this is where everybody's going. This is where Medicare is putting, it's really the movement is to alternative payment models. So 2017 is the first year that we start reporting these measures, and our adjustments will happen in 2019. So that's why 2017 is the key year, because this is when we really start kicking off a lot of this stuff regarding the program. And how you do in 2017 will determine what 2019 is going to look like for you, reimbursement-wise. There's a possibility of a positive, negative, or neutral payment adjustment in 2019, depending upon how involved, how many measures report, how many don't report going forward. The quality payment program has really two values and outcomes that it's really rewarding, and that's the advanced payment model, advanced alternative payment model, and the merit-based incentive payment system. So those are the two tracks that we're really going to be focusing on. Only eligible clinicians will be able to participate. You can participate as an individual or group. We'll talk a little bit more about that. And there are exceptions. So there will always be those exceptions for providers, so that, and we'll talk about what those are. So an eligible clinician straight off is an MD, a DO, dentist, chiropractor, podiatrist, optometrist, PA, NP, clinical nurse specialist, certified registered nurse anesthetist, and groups that include these individuals. So those right there are eligible clinicians. Now, it's not the same as a MIPS eligible clinician because there's a threshold that you have to meet in order to really be a MIPS one. But as of right now, if you fall in one of these categories, you're already considered an eligible clinician. For those of you who work in a hospital, and there's a lot of physicians that do, this is where it's going to depend upon where you work as far as what your place of service is and the volume of patients and so forth that you see. If you are a hospital-based clinician and you fall into one of these eligible clinician categories or designations, if you furnish 75% or more of your covered professional services under Medicare Part B, under place of service 21, which is inpatient, 22 outpatient, or 23 the ER, you are considered an eligible clinician. If you don't, you would be exempt. You're not considered an eligible clinician at this point. If you are considered eligible, you can participate as an individual or a group. And this is where, we've had questions, how do I determine, should my physician do an individual or group? And this is where you kind of have to figure out what does your potential group look like. Because there are four, when you're using this identifier, if you're an individual, you're using a TIN NPI identifier for all four categories, regardless of how you've been assessed. But if you're a group, you're going to be assessed against the single TIN. And that group has to have two or more eligible clinicians, so we talked about that in the previous slide, and one of those, and at least one must be a MIPS, which we're going to talk about the thresholds here coming up that designates an eligible clinician from a MIPS eligible clinician. And then their Medicare billing rights have to be assigned to the TIN. And then you aggregate the data, you're assessed across that TIN, and that's how, and you must maintain that group status for the full reporting period in order to be considered a group. So the low volume threshold, what then differentiates one, a MIPS eligible clinician from one who's maybe not and would be exempted from all of this? It depends upon the threshold that they've established. So the low volume threshold is that Medicare Part B charges are less than or equal to $300,000, or you provide care to 100 or fewer Part B Medicare beneficiaries for a year. So if either one of those, now you'd be considered exempt from the whole program. You would not be, you may be an eligible clinician, but you're not a MIPS eligible clinician. If, however, your Medicare Part B charges are greater than $300,000, or you see more than 100 patients under Part B for Medicare during a year, now you are considered a MIPS eligible clinician. And this is where the payment adjustments will start impacting you depending on your participation. When we look at low volume, they can be, these low volume physicians, clinical, eligible clinicians can be part of the groups. They don't benefit monetarily for the payment adjustments, but what they do account for, the resources, the measures that they do can be part of the group's overall combined count. So they do help with that as well. So there's really four participation options that are available for 2017. 2017 is really a transition year for a lot of things. And this is where to try to ease it a little bit, to try and get you in and get your feet wet, so to speak. A lot of these programs, these options that you'll have to pick from aren't very different from what you have now with PQRS, meaningful use, and so forth. One of the options is 90 consecutive days. It doesn't matter which 90 consecutive. It has to be beyond, as you get closer to the end of the year, you have to make sure you can get those 90 days in. But you could start like February 3rd and go 90 days from there. You could start March 2nd. It doesn't matter. It just has to be 90 consecutive days that you report your measures. The next one is a partial year. So it's still 90 consecutive days as a minimum, but you would pick that, and then you're going to report one quality measure, improvement activity, or more than the required measures in the advancing care information. I got those categories coming up. A full year, obviously, as it sounds like a full year, reporting one measure in quality, one activity and improvement activities performance category, or report the required measures in advancing care information performance category. So it kind of, they're trying to make it hopefully easy. The threshold really is 3 points that you have to achieve, and if you don't, so if you're a MIPS eligible clinician, you don't report anything, you don't participate, 4% off of every claim is what's subtracted in 2019. If you meet the threshold, you're neutral. You don't gain, there's no extra incentive payments, there's nothing taken away. If you reach the threshold and you're above it, you now have 4% per claim that'd be added. There's also the possibility of getting extra additional bonus payments as well. If you are participating in APM, I don't know if anybody is already in an advanced APM, you are automatically going to get a 5% bonus payment in 2019 because of that participation in an advanced APM. An APM and advanced APM are two different things. Yes, they are both alternative payment models, but an advanced APM is one that's been accepted by Medicare for this program. One that's just an APM may not meet the guidelines criteria that have been outlined. So there are different performance categories for which you can select your measures to report. You have quality, improvement activities, advancing care information, and cost. Now, cost in 2017 is going to have a 0 value, and they're not going to nobody's going to report with that, okay? And that's because of the time and getting it valued, and for right now, they're focusing on the first three. 2018, cost will be a measure, will be a category that you will be responsible for reporting. So what's the difference between full participation and that threshold? It really depends on how many measures you report and what you report, okay? So full participation means that there's quality category of 6 quality measures or one specialty specific or subspecialty specific measure set. Now, general oncology, we'll talk about, has a set, and radiation oncology actually has a set of measures. So that would be your subspecialty stuff. Advancing care information, 5 measures are reported, and improvement activities up to 4 activities are reported. If you've met that threshold, you're going to receive 3 points, and that keeps you neutral for 2019. So you've now met whatever it is, and you've done your part in that 90 days, and you can now kind of breathe a sigh of relief and know that your reimbursement is just going to be whatever the code value is set at. There will be no pluses or minuses for you. So here are the categories. We talked a little bit about quality. This replaces PQRS. So for those of you who are, been doing PQRS, when you look at the measures, a lot of them have carried over. A lot of changes in that perspective. So if you're used to doing PQRS, you're familiar with the program, this is going to be an easy transition, I think. The category weight is 60%. You have to do it for 90 consecutive days. There are 19 measures under general oncology, which would be a specialty, and there are 4 under radiation oncology, which is a subspecialty. So originally radiation oncology was under radiology, and comments were received that said, no, it needs to go under oncology itself, and so they agreed. So it's been transitioned and moved. So essentially there are 23 measures there that you could select from. I just have the 4 radiation oncology measures in here. I didn't put all 19 for space and time. But I will tell you, the Medicare website, the qpp.cms.gov, really is very good. I found it when looking through it, reading through the actual rules and figuring out what's going on and trying to summarize. They have a lot of really good information in there, so I highly recommend you check out. You can actually go in there and look at the different measures, and you can click on the ones that you want to do. Now, that's not how you report them, but you can select the ones that you want to participate in to kind of give you an idea. Get a lot of information in there and all the different ones that are available for you to pick as you participate. So we have one about prostate cancer, the avoidance of overuse of bone scans. There's one on pain intensity that's quantified. We've got a plan of care for pain, and then radiation dose limits to normal tissues. Those are the 4 subspecific radiation oncology measures that under the quality category that you have to select from. The next one is the integrated performance category, is improvement activities. And this one is really a new category, so there isn't anything to really compare it to at this point. It's 15%. There are actually 93 activities that in 8 subcategories. And really, this is where you're testing to completing up to 4 improvement activities for a minimum of 90 consecutive day period to qualify for that. And if you're in an APM, you'll have a lot of measures that you're already, if you're an advanced APM, you're not going to be doing the NIPS program because as part of your APM, you have quality measures that are very similar and in cohesiveness to what Medicare has established. So that's where understanding how you've established yourself, what you're going to be classified and quantified as. But there are some different measures that you can select within here to report to get potential positive reimbursement in 2019. The next one is the advancing care information. This is replacing meaningful use. So again, if you're familiar with meaningful use and the criteria and things that have gone along with that, there are measures under security risk, e-prescribing, provide patient access, then summary of care, and request accept summary of care. So it's very similar to what you've already have in place. One of the things you'll want to do is there's a link at the very bottom of the slide. The type of measures you select, there's 2 different tracks of measures, and it all depends upon which EHR edition you have. So if your EHR was certified at a certain year and it's a certain type, you're going to use these measures to select from. If it's a different one, it's these measures. So you actually can go in and you can type in your EHR that you have in there to determine which track of measures you need to be looking at to report and how to report them, because that is very important to know. And then the cost, like I said, is the one that's replacing the value-based modifier. There's no date of submission. It's going to be calculated per the adjudicated claims, but it will start counting in 2018 for then impact on reimbursement in 2020. Okay. When it comes to the data reporting mechanisms, it really depends upon whether you're individual or group. Depends upon the measure, which category that you're reporting from. Most of them are going to be some kind of registry, claims, things like that. For the group, there's some different websites that you have to use through Medicare to report those measures. So keep in mind, depending upon what you're going to be qualified as, or how you're participating, will depend upon how that information gets uploaded and sent into Medicare. So 2019, I talked about there's that 4% plus or minus. In 2020, your participation plus or minus 5%. And these are going to balance out essentially, so that when we look at the 4% and the coming in and going out, it should hopefully balance things. 5% in 2020, 2021 it goes up to 7%, positive or minus, and 9% in 2022. Like I said, that QPP.cms.gov is really a very good resource. There's a lot of different components to it that you can look at information about this. If you don't meet that threshold, that's where the adjustments happen. So you want to meet at least that 3-point threshold. And then it's really looking, it's not going to be a lump sum, like I said, per claim that plus or minus is going to come off of. And that it also is looking at the Medicare Part B payments for any of those items that have been provided. For 2019 to 2024, this is where you have the option of possible extra bonus based upon if you do more measures than what was necessary, what was defined. That actual adjustment will be defined each year by the Secretary of Health and Human Services. When it gets into alternative payment models and looking at that, this is where we're transitioning. And so this is where keeping in mind what's going on with how things are, getting started with MIPS, understanding that program, and then but knowing that the alternative payment models is where we're going with things. And there's going to be advanced alternative payment models and then other payer advanced alternative payment models are the 2 that were finalized at this time. There's very specific criteria, and an email came out after the rule was released of some new APMs for 2017. So in order to be an advanced APM, this is a Medicare advanced APM, you have to meet the very specific criteria. That's, you have to use a certified EHR. It talks about the monetary losses. So you have to meet that criteria. Beyond into the other payer, there's also very specific criteria in that, again, certified EHR, that there's a payment arrangement, for covered professional based on the quality measures. Things are going on within that advanced APM that have been designed. A little different in how some of the stuff is counted when it goes with that, and typically they're looking at an establishment through Medicare first, getting into some of the other advanced APMs. I'm trying to go through some of this quickly because we're running out of time. For 2017, these are the ones that were released in 1025. These are the advanced APMs for calendar year 2017. So you want to look and see, are you part of the oncology care model? Do you know someone who is? That's one of them for 2017. In 2018, they're going to be reopening applications for some new practices and payers, which are a couple of them. They're looking at anticipating adding a couple more in 2018 as well to be available for practitioners. And know that, again, there's that 5% bonus payment if you're participating. An eligible clinician that's participating in advanced APM, you have to have a sufficient percent of patients or then pay a sufficient amount of payment through that APM to be considered a qualifying participant. They haven't set the threshold and said what that percentage is, but that I was able to determine. So just know, even if you're working in critical access and so forth, that will be counted as well. And it's based upon those Part B claims. Again, how many patients did you see under Part B and how much did you receive under Part B for reimbursement will determine whether or not you're a qualifying participant in an APM. And then that will then further determine going forward your conversion factor updates 2026 and beyond. The all-payer combination, the first payment will be actually in 2021, and you must participate in the advanced APM under Medicare and then submit that info to CMS to determine if you've met the threshold to be in that other payer combination. So identify you, APM identifier, APM entity, the 10 NPI combinations, things that we've seen for the MIPS as well. And they're going to try and let you know as soon as they can so that you still have time if you don't qualify, if your APM does not qualify, or if you're not a QP, that you can still participate in the MIPS program and hopefully offset some kind of negative impact that may happen in 2019. There are some different ways of reporting things as well, depending upon through the APMs because of how those are set up. And so that's where, again, for those of you in the APMs, it will make a difference as to, and looking at the structure of the APM and how things are set up for reporting purposes. When it comes to physicians, we talked a little about this in hospital settings, some of the things when it comes down to that meaningful use and the categories. And CMS understands, I wanted to touch on this because I think I skipped a little bit of it, that for some of you, if you're in a hospital base, they know that as a physician, you don't always have those decisions with the EHR that's being used. And so if that is the type of setting you're in, we'll look at that category will likely not be counted against you because you don't have the input to creating that EHR. It's not always getting the input that you need and the information out to support you in this. So that would be something that may also adjust if I don't believe I touched on that at the time. Whew. Okay. That was a lot of information, and I know I went through some of it quickly. I think some of it comes down to, figuring out for yourself what's, where you are, what you're going to be established as. We did have a question that comes into provider-based departments. It comes down to when you set yourself up as traditionally, the provider-based department was affiliated with the hospital, and you're considered a hospital department, but you're within that traditionally was a 35-mile radius from the main building of the hospital. And what happened as part of the Bipartisan Budget Act of 2015 is that they found that there was a lot of services that happen in a hospital, happen in a freestanding cancer center, happen in ASC, the exact same service paid all different amounts. And typically in the hospital, it was much higher. Hospitals have been acquiring physician practices and physicians at an alarming rate. I think from 2012 to 2015, there was a study that was recently done about 85% acquisition of hospitals acquiring physician practices. That's huge, especially when the reimbursement is higher. So they need to neutralize some of these payments. So the Bipartisan Budget Act put into law as of November 2nd, 2015, if you billed Medicare and the date of service was prior to November 2nd of 2015, and you are within that 35-mile radius, you are considered accepted off-campus provider-based department, and you will continue to bill on the UB. You will continue to be paid under HOPS. If you are a new provider-based department as of November 2nd, 2015, and you are within 250 yards of the main hospital building, you are also considered and accepted. You would be considered on campus, and so you would also bill under UB and be paid under HOPS. If you are a provider-based department that even if you were open prior to November 2nd, 2015, even if you were mid-construction, but you had never actually, there was no date of service prior to November 2nd, you are considered a non-accepted. And what that means going forward is that you still bill on the UB, you still follow the hospital guidelines with regard to supervision and rules like that, but your payments now are going to be following under MPFS. And actually what they're doing, until they have this really all lined out in 2019, your reimbursement next year, if you are considered a non-accepted off-campus, is going to be 50% of the HOPS rate. So when you look at a code and HOPS has 77290 and it's this, 50% of that is what you would actually now make in a non-accepted provider-based department because you are outside either that 250 yards and you started after November 2nd, 2015, or, that's basically it. If you're within that, you're considered on campus. So there's some very distinct differences. And also, if you're considered non-accepted, you will now be billing the G codes for treatment and IGRT. So if you've been status quo for some time, this is where you need to get in touch with your management. Find out exactly how you qualified yourself when you opened the CMS. Did you qualify yourself as provider-based? Where are you at distance-wise from that hospital? When did you first bill your first service to Medicare? What was the date of service for that? That will determine what your reimbursement will look like in 2017 and going forward. So hopefully that answered the question that we had there. Okay. All right. Well, that's it, everybody. I know we're right up in just over the hour here. I hope that this information was valuable for you. I hope that there was some good stuff in there. Again, if you had any questions, you can use that info@revenuecycleinc.com email address. And if you did not receive a copy of the PDF of this presentation, you can request that there as well. Otherwise, look in the email for the registration email, and that's where it actually was emailed and sent. Thanks, everybody. Have a great rest of the day.